When the definitive analysis here on malpractice costs has been done by the Congressional Budget Office. Let me remind you who they are. They're the scorekeepers in Washington who assess legislation and what impact it would have on the federal budget, but they've also gotten into assessing more general things at the request of various congressmen. So in the heat of healthcare reform, Orrin Hatch, a Republican senator from Utah, to try to nudge healthcare, a certain kind of malpractice reform into the bill, asked the CBO to evaluate what a malpractice reform would do to healthcare costs. The idea being, if he could show that malpractice reform would drive down healthcare costs, there would be a good rationale for putting it in the bill, and he would actually back Democrats into a corner. The politics being that Democrats represent, the Tort Lawyers Association, and Republicans are more aligned with the doctors, and so he could back the Democrats into a corner to include malpractice reform. So the CBO did a review, and basically it said, look, for almost all of proposed malpractice reforms, we have no idea because there's never been a good test of them and never been a good study. But across the country, there have been some reforms that went along the line of the following. Caps of $250,000 on award for non-economic damages. So you can differentiate economic damages, lost earning, disability, from non-economic pain and suffering. Cap on awards for punitive damages, how much you want to make a show of this doctor and this outrageous behavior, to $500,000 or 2 times the award for economic damages. Modification of the collateral source rule, which is everyone else getting involved. Statute of limitations, so reducing when people can sue from 1 year after they learned about the problem in adults, and 3 years after they learned about the problem if the injury happened to children. And then replacement of joint and several liability with fair share rule. So joint and several liability means I sue the hospital, this doctor, the nurse, that doctor, everybody who came within 100 feet of my bedroom in the hospital, right, gets sued. Now typically, the way joint and several, and the lawyers will help me if I'm wrong here, works is that whoever's got the deepest pockets, they're responsible. Even if their share, it's turned out that the jury says they were responsible for 10% of the injury, they could be responsible for 100% of the payment if no one else has any money. Is that right? Okay, I got it right. Amazing. And I'm not even a lawyer yet. Fair share rule says, well, if the hospital is responsible for 10% of the negligence, they're only responsible for 10% of the settlement. And if the doc has no malpractice, has run away to Guatemala, right, and you can't get that, you don't get that 90%, and the hospital's not responsible for that 90%. You implement this 5 set of reforms, and what amount are you going to save on defensive medicine? 100 billion, 50 billion, 25 billion, 10 billion, 5 billion. So most of you think 10 billion, or 40% of you think 10 billion. Nice bell-shaped curve here. 25, 5 billion, 25, 25 billion. So if those of you who thought it was 25 billion basically think more than a third of defensive medicine would go away if we changed the malpractice system. So if you implement all of those reforms that were listed, reducing the non-economic damages, getting rid of the joint and several liability, changing the statute of limitations, you'd reduce, the CBO estimated, based upon previous studies, about 10% from the malpractice premiums, settlements, and administrative fee. If you implemented that proposal, you would lower defensive medicine by about $7.5–8 billion. All together, all of those reforms together, both changing the medical premiums and changing defensive medicine would amount to $11 billion. Okay? How big is $11 billion of the total healthcare spend? 2.6 trillion? Right? 0.5%. Less than 0.5%. What do you know about $11 billion as a proportion of the year-to-year change in healthcare costs? What? It's about 11%, right? Remember, I told you way back when, probably in the second class, if I can remember, that between 09 and 10, healthcare costs went up $100 billion. And this would be about 10% of that. Let me just say, that $100 billion, that's a really, it looks precise estimate, but it's really a guesstimate. Could be anywhere from about 80 to about 120. We don't have a really good accounting system. When you get up to those kind of trillions, you're looking at 5,000 hospitals, you're looking at 800,000 docs, not to mention all the home health care agencies, nurses in the system. So $11 billion is kind of like, crudely speaking, pencil dust in the system. It's about the uncertainty, or actually it's smaller than the uncertainty in how much we're spending on health care. You would not notice it year to year because the gyration in the inflation rate is so much. So when doctors, if you ask most doctors, and again, when you go home for Thanksgiving or spring vacation and you have a friend or a family friend or a parent or a cousin who's a doctor, ask them if they were going to control healthcare costs, what would be the first thing or the first, second, and third thing that they would do? Malpractice reform is on that list. When I go around and talk at medical schools about healthcare reform, one of the first three questions, guaranteed. It's a very unusual group at a medical school. If I give a talk on healthcare reform, that not one of the first three questions is about malpractice reform. Doctors are obsessed by it. And yet, these data suggest not really important from a cost standpoint. Not really important from a cost standpoint. If you're a neurosurgeon and you open up a practice and your malpractice costs are $350,000, what proportion of your billings, one way of looking at it is how many days do you have to work to earn back your overhead, where a big portion of your overhead is your malpractice costs? I don't know the answer to that question. Neurosurgeons make a hell of a lot of money. OB-GYN people are a different story. And there's definitely, especially in OB-GYN, definitely a trend to to people who are trained in OB-GYN to getting out of OB and going to gynae. Now again, we have a multiple motivation problem, okay? What's the other motivation? Know anyone who's delivered a baby? When do you deliver babies? At 2 o'clock in the morning, right? By the time you get to my age, being up at 2 o'clock in the morning, delivering a healthy baby, that's a thrill, but it kind of gets boring, right? You'd rather be in your own beds horizontal rather than vertical, bleary-eyed. And so there are these problems of, yes, you can blame, I'm getting out of obstetrics, and again, blame malpractice costs, but you have to say, well, are there other motivations that might be making this complicated? I'm not saying that in that case, the lawsuit rate isn't making a big motivation. The fact is, if we go back to that slide, maybe I'll go back to the slide, sorry. I think I'm going the correct direction. What do you know about the people at the top? They make a whole lot of dough. They also turn out to be the people at the top of the food pyramid in medicine, right? Neurosurgeons. You're going to pay a lot of money to have someone operate on that very important organ. Cardiac surgery, general surgery, orthopedic surgery, plastics. These are not pediatrics. Those are the poor people in the system. Or family medicine. So there is a relationship here between very well paid and a higher risk, and not so well paid and a lower risk. So when they complain, I think it's real, but it's a very small violin I would play for them. Okay? There are a bunch of other proposals out there that haven't been tested for their impact on healthcare costs. or quality, for that matter. I'm just going to list them. So one is pretrial screening panel. So some places have set up a panel where a lawyer has to submit the cases, and the panel looks over the cases and says, this shouldn't go forward, and there is some plausibility to this case, go forward. The effect, places that have that, for example, are Cook County in Illinois and a bunch of other places. The effect on malpractice cases, anyone want to guess? Huh? Negligible. Cannot tell the difference. Second, limiting liability. We already discussed that. Health court. So there's an idea that part of the problem of malpractice cases that actually get to trial is you got a lay jury, don't know anything about the case. They got a sympathetic, kid in a wheelchair, and so they want to reward the kid. And the easiest way to reward the kid for what's going to be a crummy life is to take the money from the hospital and doctor. Ignorance rules supreme. Let's get specialists in here. Judges who only deal with this, judges who have the ability to get specialists involved and consult to really read the record, to make it more of a specialized profession. Kind of like the way patent law is, that only goes through specialized courts. Hasn't been fully tested. The few places where it has been tested doesn't change costs at all, because actually running these courts is pretty darn expensive. Safe harbor. So this I will take credit for. The basic idea is that doctors should be presumed not guilty in a case if they can show that they followed a guideline, they installed electronic health record, that health record had a decision support that told them the right thing to do, and they should have a presumption of innocence. Now, you can't say you can't be sued, but they should have a presumption of a protection, and so it would be a higher threshold for a proceeding. We thought that actually would accomplish the first goal, which was to get doctors to perform better by adhering to guidelines better. Hasn't gone anywhere. National Medical Error Disclosure and Compensation Bill, the so-called MEDIC bill, was introduced by Senator Barack Obama, co-sponsored by Hillary Clinton when both were in the Senate. And it's based upon the Michigan approach of saying sorry. And this goes to some research which I haven't discussed, which basically finds out the following. Why do those people who had an adverse event not sue? I believe one of the studies in general about tort lawsuits, that is about suits for negligence, is they're not typically about the money. They're typically about wanting justice and wanting to be treated well and to be told and to have someone say, I'm sorry, I screwed up. And so if you look at a lot of the cases, and outside of medicine, it's not really, you would think it's all about the money. Something bad happened, you want to get the money. A lot of it is just you want to be treated with respect. You want someone to apologize to you. And so the malpractice system, as it's conceived as an adversarial process, does just the opposite. What's the first thing the hospital lawyer tells you to do if you're a doctor in this system? Don't say a thing. No, forget denial. Just don't say a thing. Don't talk to that patient. Get away. Don't have communication. It'll be just lawyer to lawyer. Right? That is completely counter to the psychology of the situation. It may be good law because the law has created this adversarial process, and anything you say to the patient might be used against you in court. But the psychology of the situation says that is really dumb. So this saying sorry process has the following characteristics. It promotes open communication between patients and providers. That is, the moment you've seen that you've done something wrong, you go and tell the patient and you say you're sorry. They then the hospital provides a set guideline, given what the error is, to compensate the patient. So someone comes in and doctor says that they're sorry, explains what happened, what went wrong. then a representative from the hospital comes in and says, here's what our compensation structure is for this injury, and gives them a number right away. And then that's it. Court is, they can not reject it and still go to court, but they can resolve the problem much more quickly, and the patient can feel whole. So the article summarizing this approach is, we apologize and learn when we're wrong, so that's the advantage for improving care. We also explain and vigorously defend when we're right. Court's a last resort, but they also want to make sure that there's a certain kind of fairness to the patient. It's not only those patients that complain that get compensated. So what's the consequence? These are results from the University of Michigan. Their litigation costs went down 2/3. Their average time to resolution of claims went from 20.7 months, so nearly 2 years, down below a year. And their number of claims and lawsuits cut in half or more. So this SARI, and I think their dollar layout, separate from their litigation claims, has gone down substantially as well. How effective is this if we know that a lot of the lawsuits aren't a result of negligence? If you have this in place and your patients know it, two things happen. First, you understand that if you're harmed, the hospital's going to come, because of negligence, the hospital's going to come and tell you, so you don't have to actually know and go out and get a lawyer to try to discover it. So more people will be compensated who actually have had the negligence. Everyone will be compensated at a lower rate. There are none of these multi-million-dollar claims for some people and zero for others. There's a more uniformity in claims, so it's a more fair procedure. And also, you can be pretty sure that if the hospital didn't contact you, you're unlikely to win in court, because they don't think they did anything wrong and they're going to vigorously defend themselves. So the fishing expedition aspect of it goes away. Now, Michigan's had a lot of success. They've gone around the country proclaiming their success. They convinced Senator Barack Obama that this was a good idea and that it should be a model for his legislation. What's the problem with that? Well, the hospital has an incentive. I mean, the hospital wants to do the right thing, and mostly the hospital wants to reduce errors in the future. And if they find out, if everyone has a culture of reporting mistakes, you find out very quickly where your mistakes are, and you can, again, if you believe it, it's a systematic or structural problem typically, you can then target what you're doing. There's another problem about this. Yeah? Trial lawyers? No, this put the trial lawyers at bay, because they know that they've already settled. I mean, if you wanted to generalize this in law, yes, the trial lawyers are not happy about this. Why aren't they happy about this? They're cut out of most of the deals, and the average settlement is much lower. So even if they got involved, they don't make as much money. So that's from a legislation standpoint. The politics of healthcare reform and malpractice. I'm just going to summarize briefly here for a second. There was no way malpractice was going to get into the bill unless one of two things happened. Okay? The Republicans wanted to come on and we're going to play ball about we'll compromise and we'll try to shape the bill, and for our vote we need certain things, among those malpractice reform, so we could deliver to our constituents, the docs. Since the Republicans' response to the bill was no way, no Democrat was going to listen to them. Why listen to them? Why put malpractice reform, which is their issue, into the bill if they're not going to compromise and vote for the bill? So unless the Republicans were going to be grown up and negotiate about the bill, wasn't going in. The only other way it could have gone in is, who's a political scientist in the room? What other group could have pushed malpractice into the bill? The doctors, AMA. They could have said, no support from us unless you put malpractice in the bill. Now, publicly they said that. Privately, they didn't push malpractice. Their number 1, 2, and 3 issue? Who? What? Yes, physician compensation. Who said that? Yeah. Money, money, money. And so malpractice was always way down the list. So why should the Democrats put it in if they don't need, they can, talk to docs about money? So that's why it never made it into the bill. So recognizing that malpractice wasn't going to be in the bill, and by the way, I should tell you, I know, because I was a big malpractice proponent in the reform, was President really wanted malpractice reform. He really wanted it. He believes that it's important psychologically for doctors to get the monkey off their back so that they don't always use it as an excuse. But no deal. So instead, in September '09, he gives a speech before Congress where one of the things he suggests is we'll give out these grants to study malpractice reform. That's the best he can do.